Okay, today we're going to talk about the clinical chorioamnionitis from the William textbook 26th edition. The clinical infection is a major concern with membrane rupture. Although some cases remain subclinical, if chorioamnionitis is diagnosed, prompt effort to effect delivery. Preferably, you should go for vaginal delivery or initiated. Because of maternal leukocytosis alone is not a consistent finding. So fever, remember this thing, fever is the only reliable indicator for the diagnosis of chorioamnionitis. This is the highlight point for this topic. Fever is the only reliable indicator for chorioamnionitis. Then, institutional practice protocols vary in defining the temperature threshold. Traditionally, a temperature of 38 degrees centigrade, 100.4 degree Fahrenheit rupture membrane has implied infection. In 2015, a workshop sponsored by the NICSD was convened and suggested a renaming this. Now they renamed the clinical chorioamnionitic condition to a intraamniotic infection and inflammation, triple I, that is intraamniotic infection and inflammation. This is triple I. They renamed in 2015. They renamed clinical chorioamnionitis condition to intraamniotic triple I intraamniotic, I infection and inflammation. The merits of this terminology have been questioned. Nonetheless, the ACOG 2019 revised both the definition and temperature threshold for intraamniotic infection. Using this new definition, how will the diagnosis of suspected infection is made when the maternal temperature is more than 39 degrees centigrade, or when you will diagnose suspected chorioamnionitis, that is when the temperature is more than or equal to 39 degrees centigrade, or when the maternal temperature is 38 to 38.9 degrees centigrade and one additional clinical risk factor is present. The latter include what are the risk factor? The low parity, multiple digital examination, internal uterine and fetal monitor, meconium stain, amniotic fluid, and the presence of certain genital tract pathogens such as group B streptococcus infection, sexually transmitted agents. Remember this, isolated maternal fever is defined as any maternal temperature between 38 to 38.9 degrees centigrade with no additional risk factors. The risk factors are like low parity, multiple digital examination, internal uterine fetal monitor, meconium stain, amniotic fluid, presence of certain genital tract pathogens like group B streptococcus, sexually transmitted agent, no additional risk factor present with or without persistent temperature elevation. Remember this, with chorioamnionitis, fetal neonatal morbidity will substantially increase. Okay, Alexander colleagues study very low birth weight neonate delivered at Parkland Hospital. Approximately 7% were born to women with overt chorioamnionitis. Their outcome were compared with similar newborn without clinical infection. Those in the infected group had higher incidence of respiratory distress, alien seizure, ventricular hemorrhage, periventricular leukomalacia. Colleagues found that intraamniotic infection in preterm neonate associated increased risk of cerebral palsy. Antimicrobial therapy. Various antimicrobial have been evaluated for stall preterm delivery. Review 13 randomized evaluated the antibiotic for PPR and before 35. The meta-analysis indicated only 10 outcomes were possibly benefit. Fewer women develop chorioamnionitis. Fewer newborns develop sepsis. Pregnancy was more often prolonged 7 days in women giving antibiotics. However, rate of other neutral outcome include survival, respiratory distress was unaffected. Women with membrane rupture between 24 to 38 gestation. The treatment included intravenous ampicillin plus erythromycin over 6 hours for 48 hours, which was followed by oral amoxicillin plus erythromycin every 8 hours for intravenous ampicillin plus erythromycin every 6 hours for 48 hours, which was followed by oral amoxicillin plus erythromycin every 8 hours for 5 days. Neither tocolytic or steroid are given. Antimicrobial treated women had significantly fewer newborn respiratory distress, necrosis and tocolytis. Composite was not outcome. Remember this, amoxiclav is contraindicated Amoxiclav is not recommended, however, because of its association with an increased incidence of neonatal necrotizing enterocolitis. A single course of corticosteroid is recommended for pregnant women with PP around between 24 to 34 weeks 7 days. Obstetrician Gynecology SQG 2020. A single course of steroid as early as 23 weeks 7 days at risk of preterm delivery within 7 days you can consider. Similarly, the controversy is if to start 34 to 36 weeks 7 days with rescue therapy. The management of preterm labor with intact membrane. Women with sign symptom of preterm labor with intact membrane is managed similarly. Those PPR may possible to deliver before 34 weeks gestation delay. Drug used to avoid the suppressed preterm uterine contraction as subsequently discussed. The amniocentesis to detect infection. 1 of every 10 women with preterm labor and intact membrane will have an intra-amniotic infection is largely subclinical. Because of this, several tests have been used to diagnose intra-amniotic infection. Although such infection can be identified with positive test result, routine amniocentesis offer little value. A single course. The single course of corticosteroid currently recommended for women between 24 to 34 week gestation who are at risk for delivery within 7 days. ACG 2020. Recommended for premature twin has been challenged. Pregnancy at 23 weeks at risk for delivery within 7 days. Single dose corticosteroid may be considered. Administration of corticosteroid during the previous period is linked to parental decision regarding resuscitation should be considered in that context. If you infant exposed to repeated course of steroid and non-significant rise in the cerebral palsy rate was identified, the rescue therapy. The refer to administration of a second corticosteroid dose when delivery become imminent more than 7 days have elapsed since the initial dose. In one randomized trial, 320 cc placebo or single betamethasone. Practically, the rescue dose of betamethasone increases gradually. In another randomized trial, significantly lower rate of respiratory complication and composite outcome versus placebo rates parental mortality improved. Single rescue course should be considered in women whose prior course was administered at least 7 days previously who were less than 34 weeks gestational. SUG note that single rescue course of anti-steroids should be considered in women fetus less than 34 weeks whose prior course was at least 7 days previously. Effect of rescue therapy beyond 34 unknown. No advice. Maxel for very low birth weight neonate whose mothers were treated with Maxel preterm preeclampsia or preterm or labor or preeclampsia found to be reduced incidence cerebral palsy at 3 years. Magnesium exposure improves parental outcome. It is both neonatal death and cerebral palsy are lower in the Maxel treated group. More convincing evidence for Maxel neuroprotection came from the randomized MFU network study, beneficial effect of antenatal Maxel sulfate beam study, beneficial effect of antenatal Maxel study. 20 to 41 mn imminent risk of fetal birth, 24 to 38 next gestation Maxel for placebo. Maxel was given 6 gram per hour, 20-30 minutes followed by maintenance dose 2 gram per hour. Maxel usually actually infusing at the time of delivery. Half of the return infusion continuous protocol by India. If delivery again is imminent, if 6 are first, this 2-year assessment 96% will be in trial. Result is finding to mean that Maxel infusion prevents cerebral palsy regardless of the gestational age which therapy is given. Those with different view conclude that this trial only support use of Maxel for prevention of